bit of technological hassle here. We are back. So my topic for the day is anxiety, delirium agitation, and dementia in palliative care patients. So what is a psychiatrist, doing here in a palliative conference? So, the ICU setup, chemotherapy rooms can evoke a lot of reactions even from the best of us. So coming to anxiety. So anxiety is a feeling of intense, excessive and persistent worry and fear about everyday situations. In a palliative patient, it can be manifested in a form of acute anxiety, nervousness, feeling of impending doom, panic attack, palpitations, hyperventilation, the whole autonomic arousal symptoms. Chronic anxiety can manifest in the form of worries, inability to relax, irritability, anger outbursts, and restlessness. We can also divide anxiety symptoms for better understanding in the form of physical symptoms and psychological symptoms. So physical symptoms will be those of hyperarousal, like I mentioned before, autonomic hyperactivity, palpitation, sweating, agitation, GI disturbance in the form of nausea, loose motions, frequency of urination, insomnia. Psychological symptoms in the form of worries, phobias, negative thinking, poor concentration. These factors can actually confound many other medical conditions. That's why we need to be aware about it. Anxiety is common in palliative care patients. I think you all are dealing with these kind of patients day in, day out. We know that it adversely affects the quality of life. It impairs daily functioning. It impairs the ability to cope with illness. It reduces treatment compliance. This is one of the most important reasons. Anxiety also makes life pretty difficult for the caregivers, including the doctors and nurses. Patients don't cooperate, and physical symptoms become more difficult to manage. So in a patient, if of possible anxiety, what are the assessment? Firstly, clarification of the presenting symptoms. We have to also see whether this patient is having a previous history of anxiety or depression. Many of them do have. And also previous history of substance use, nicotine and alcohol withdrawal, or intoxication can look very much like anxiety. Personality factors and family and social support will also affect the anxiety experience and the objective visibility of the anxiety. As far as the assessment goes, there are many scales to check out and rate the anxiety of patients. The most commonly used in ICU settings and in palliative care homes is the Hamilton Hospital Anxiety and Depression Rating Scale. So I'm just listing out the items in the scale. Maybe it will ring a bell. So waking up early and then sleep badly for the rest of the night. It's a Likert type scale, so you have to rate it patient has to rate it from 1 to 5, or the nurses and the caregiver can also rate it for the patient. I get very frightened or have panic feelings for apparently no reason at all. Feel miserable and sad. Feeling anxious to get out of the house on their own. Have lost interest in things. Get palpitations or sensations of butterflies. So these are the negative scored ones. So I have a good appetite. I feel scared or frightened. Feel life is not worth living. Whether the patient reports that they enjoy the things they earlier used to. I feel restless and calm, can't keep still. I am more irritable than usual. I feel that things have slowed down and worrying thoughts constantly go through my mind. These are the items of the HADS, and they are subdivided into anxiety and depression, and we have to score it. Anybody more than 10, 11 is positive for anxiety. That gives us a guideline as to, go for the management. So I am covering mainly the pharmacological management. There is an immense amount of psychological and non-pharmacological management required for anxiety patients in palliative care setup. So that will be covered by the next speaker. So usually anxiety which is occurring for a shorter duration and treatment hence which is required for a shorter time, for a period of hours to days. Anxiety before a procedure, anxiety before taking the chemotherapy, so those kind of short periods, bursts. So benzodiazepines usually are the drugs of choice. Lorazepam is a commonly used one. It is available in tablet and parenteral route. Usually the effect is within minutes to hours. It lasts for a good 5 to 6 hours. So we can expect that much effect. One of the oldest benzodiazepine is diazepam. That also is a pretty popular choice. For oral tablets, which need to be given for daily use for a few days perhaps, clonazepam is a good choice. Oral administration. Midazolam was also earlier covered by the previous speaker. So usually intravenous administration. Short bursts of anxiety, especially pre-procedure, is usually, it takes care of the anxiety. Benzodiazepines are well tolerated, safe in, kidney and renal dysfunction, which is very important for, to keep in mind for the palliative care patients. If you are expecting or suspecting the anxiety which is long-term or previous episode and we are wanting to give treatment for maybe days to weeks, SSRIs are the drugs of choice. We have SSRI and we have SNRI. Amongst the SSRI, we have escitalopram, which is a 5 to 20 milligram per day dosage. Usually the trick is to start slow and build up the dose, and we can see the response in around 5 days to 3 weeks is the optimum dose. So usually we see the effect within the first week of treatment. Effect is lower than benzodiazepine, okay? So peak response is expected at around 3 weeks. Usually SSRIs are recommended for when you want to give treatment for a longer period. And usually minimal interactions we expect for palliative patients. They are already taking a couple of other medicines, so they have a reasonably good safety profile. Nonetheless, in specific patients, we do have to look at the interactions carefully. So now jumping into delirium and agitation, usually they go together. So I have clumped it. So delirium, I think we all know, it's a bit of revision for us today also. So delirium, also known as the acute confusional state, acute confusional. So that everything is in that. Delirium is an acute syndrome. It is characterized by acute disturbance in mental functions, namely attention, concentration, and cognition. It is very often an acute organic process which affects the brain. So the symptoms are impairment of consciousness and attention. There is a global disturbance in cognition. The thinking gets affected, the concentration gets affected, the patient could be hallucinating, cannot comprehend what you are saying, disoriented to time, place, and person. It's acute. Psychomotor disturbances can be of any kind. Hyperactivity is common, so is hypoactivity, and even mixed phases in which a patient may shift from hypo to hyper in a couple of hours. Disturbance of sleep-wake cycle, insomnia, reversal of sleep-wake cycle, nightmares, very common in delirium patients. Emotional disturbances like irritability, anxiety also are very often seen.